Okay, Bhupati and Dr. Vijay Kumar, and we saw other chairperson getting there and panelists. Can you see us and hear us? We can hear you very well.
Yeah, Samin Ramesh here. We can hear you loud and
Ramesh.
clear.
Beautiful. All right, Ramesh and all the team there, thank you. Welcome from Mount Sinai, 11 p.m. in the night time. And with just getting you guys started, I'm so happy that everything going on time. And we welcome from Mount Sinai myself, Dr. Kini, my left side. Then we have fellow Dr. Mahadir Gadela and Dr. Karthik and our rest of the team, including imaging. So we are all ready. And thanks to the Tamil Nadu Interventional Council committee to give us a chance to showcase left main, knowing that was a case of the imaging and left main, and that's what we actually have. Very beautiful case for presentation. If okay, we want to go ahead and quickly go through the case and in next 2 minutes because it will require a little extra time to perform the case in a very succinct and good way, completing way. We not finish in the middle. So this is myself and Dr. Kini. This is the case, 81-year-old patient presented to outside hospital with progressive class 3 angina and dyspnea on exertion. Patient has a preserved heart failure with preserved EF and was managed no MI. Echo revealed mild MR, mild pulmonary hypertension, and had a severe calcific 3-vessel disease, which I'll show. Also has uncontrolled hypertension on the left side and creatinine of 2. So CKD stage 3. More important is patient very frail. So patient, the BMI is 19 and height and weight very petite patient, and because of that weight is 146 kilo, height is 152 centimeter. With the despite significant CAD, surgeon did not want to take care of the patient, and that's where we are now, and we can show what the angiogram showed here. So Anu.
So this is where EDP about 16, a normal EF.
No, it was 25 earlier.
Now
Yeah.
it is 16.
Yeah.
Yeah. So we have a right coronary artery, proximal significant disease. Mid is okay, and calcific 95% disease in the distal RCA. This is the left main, significant distal left main, bifurcating, involving LAD, prox LAD, and even the circumflex.
Let's look at this one. Very, very calcific chunk. I mean, I won't even call it a severe calcium. It's like, you can call it even dystrophic calcium. So extensive or massive calcification and significant lesion distally, although despite patient had high ADP, despite normal ejection fraction, the question is what you do for these complex patients. So that's where the comes down. Let's quickly continue our presentation and then we are ready for wiring and show it. So basically the plan is for high-risk PCI of this complex left main and multi-vessel CAD with IVUS in the end for optimization because creatinine is 2, and use a rotational atherectomy plus IVL for this purpose. Question is Impella versus no Impella. As we know, the latest updated guidelines, heart team, STS risk, syntax score, and frailty. They actually really have given importance that maybe your STS score and those things are different. Some patients are very frail, and this exactly the patient is 81, frail, high creatinine. No surgeon will touch this patient despite the normal ejection fraction. So if we put into our equation of the OC, it will be appropriate. STS risk was 5.4 for this patient with age of 81. No valve, significant valve disease. And this actually guidelines also updated one on the left side in the center with the left main. Yeah, it's a very complex. Of course, we want to send them for CAD for cabbage. But look at this one. That if the patient is suitable candidate for cabbage but not suitable, your heart team discussion is class 1 indication if you want to combine with the PCI and guideline directed medical therapy. So that's where we are, and we are ready in terms of what to do. And we decided in this particular case, maybe some people may have some controversy that should we not, and we'll speak to the, you take the opinion of the panelists. Because of the severe calcific disease, we felt with the lesion complexity, calcium comes into factor, that creates more trouble. That EF 20 to 40, clearly extensive revascularization, you use impella, and of course the low EF you always use some support. But in this particular case, because of the normal even EF, we felt that impella will be appropriate with a high LVEDP. With that note, what we have done is we have put a left, this is not a single axis. We have used the impella on the left side with our regular LP, and we are ready with the 7 French guide. The plan is do the rotational atherectomy with IVL and do the imaging as the time will permit. I mean, not time means probably in the later part of our management treatment of this patient. So with that note, I'll leave to the or our panelists and everybody else to discuss while we are planning to do rotablation with the 1.75 bar of left main to the LAD, and then we'll decide what to do for the circumflex.
So with regards to crossing, we have a 7 French. You see that we have a femoral axis 7 French guide. This is a VL guide. And then with the fielder fine cross, I was able to cross left main to LAD. We're just changing into the rota wire, and we have a 175 bar ready.
Yeah, the rotor
So we
drive
can
floppy wire, yeah.
show the hemodynamics by the side.
They should be showing the hemodynamics on the side, because that will be important. This particular patient has uncontrolled hypertension. Yeah. Why is it okay? Yep. Even now,
What was
on
the
multiple medical therapy patients, still blood pressure right now is 180.
EDP earlier was
Earlier was
26,
25,
but
and just now, because then I gave diuretic and we put patient on nitro, and now it's still high systolic pressure. But when they open now at the time of impeller now, it was 16.
Thank you, Samin and Anu. I'll ask now Dr. Mulasari to go.
Thanks, Ramesh. Morning, Samin and
Keep going.
Annapurna.
Yep.
Very nice case to demonstrate. The first issue is the use of the impeller in these group of patients. Obviously, it's not a high-level indication on paper, but really a normal LV function with a high EDP and rotablator with the chance of having microembolization becomes reasonable. To put in some
3520,
sort
okay.
of support.
And particularly the RCA is
I
also
suppose that's-
subtotal. RCA is subtotal in this particular case.
That's correct. So I think I would sort of agree that we need some support to start the procedure. And I think, doing a rotablation would be the first strategy to clear that bulk of the calcium path, and then possibly use an IVUS and then follow it up with an IVL maybe to maximize your debulking. So I think I would sort of agree with that
What is
strategy
going on?
in
Why?
what you're doing, this patient.
Okay. Very good. Ramesh, what would you do in your lab there here?
Yeah, I agree with what you're doing, Dr. Sharma. I would go with either EDP or right heart cath assessment prior to deciding on the device. And here in this triple vessel disease and frail elderly patient, our ultimate goal is to make sure the patient comes out of the lab alive.
Yeah.
And whether the guidelines do support or not, I think it is better for me to have a backup in this patient. I know we are still doing Protect 4, and on also the other trials which probably will support use of a device or not in the future, but we can't wait until those guidelines come or those clinical trials make an impact on the guidelines or not. So let me ask you, do you have ECP in your lab? Are you part of the ECP trial?
So I'm
ECP. Which trial?
Do you have ECP? Just because of the low body weight, I was wondering whether you would have preferred if you had a choice.
Yeah, no, that is that is only for the trial yet, but not this kind of patient, because the normal EF will not allow that.
Now, are you seeing the see the drop in blood
See
pressure?
the drop
Did you
in blood
give
pressure
anything?
despite that.
Okay, come out.
Done?
Yeah.
Yes, we
Yeah. 180. Look at the 180 blood pressure became.
No, IVUS, no?
Anu, at the same time,
No,
the
IVS.
impeller flows were good, right?
Yeah, yeah. What's the flow over there? Okay. It's a, okay, good.
And patients so far keep sedated good. Let's take a little picture question.
And also creatinine is high. We have to be cautious
Yeah.
with the use of dye in
Yeah,
this.
so that's where the imaging can come in, replacement part of it. So question is, do we go with the 3.5 or 4.0 IVL? I think go with the 3.5.
Ideally, you should image now.
Huh?
Do we have
You
a
should image now.
for,
Yeah,
Okay.
I think we should image now to understand the amount of calcium. No, we can go IVUS on this
No,
one.
no, this one.
We'll go.
No, but
not
what
only
is
that,
it going
to
to
size
achieve
the
by that?
IVL balloon,
Yeah,
it will be helpful.
yeah.
Okay.
Okay.
Annapurna, you're using the handheld rowers or are you using the foot pedals?
No, now
Oh,
we
this
actually,
one,
the Rota
no,
Pro,
Rota Pro, which
gave
is-
about 3 years ago kind. And you see that this is all come with a set already 155 preset from the company. So not very little manipulation you require. And so, but there are a lot of good stuff. The another point which has not come to the Rota Pro 2, where the advancer knob has also the Dynaglide. So right now the Dynaglide button is on the side, but then we put that button on the top. So that will be coming soon also, Rota Pro 2. But a very device definitely has become quite friendly. All those tachometer, separate pedal and all those things and made life quite easy. But I know the issue has been the cost has 2.5 times in India so far. In America, changed maybe by 25%. But we'll see. Hopefully they'll settle the prices there too.
Okay, we can start showing the IVUS. Yeah, come
So we're
closer.
doing the IVUS right now.
Yeah, yeah.
Dr. Kini and
Bhupati.
Dr. Sharma, this is
Yeah.
Bhupati here.
Yeah, Bhupati,
Yes.
yes.
So what I would appreciate if you could let us know the Impala strategy. It's a 2.5 or CP, and then about the two stent or single stent strategy.
Yeah.
I'm very sure Dr. Sharma would have considered 2 burr
Okay, can I
in
start
this
from
particular
here?
patient.
Okay, it's a good place. Okay, I'll start from back.
No, in the before IVL was there, yes, if you wanted to do aggressive debulking,
Yeah, here's
we
a
still would have done a
eccentric
bar strategy. You know, you would have gone 175
We
first
can see
and
the
then
eccentric calcium.
go to a larger bar.
Yeah, a lot of plaque. Yeah.
Look at this.
Eccentric.
And
This part is
circular
normal,
calcium.
But at 270 calcium. Yeah,
But
here's
here,
the 360
360
calcium.
degree.
Yeah, 360 calcium. Yeah, looks like ablated calcium. Yeah, we can see the big branch. Sorry, the dark image.
Okay.
Okay, here, yeah.
Coming close. Yeah, still proximal LED. Yeah, here's the
And-
lumen.
No,
bit.
that's
left main.
yeah,
left
that's
main.
the left main. Yeah, that's the left main.
Good.
Here's not much plaque. Yeah.
So I think it looks like that there is a circular calcium.
Yeah.
At the distal left main, show us, and if you
Yeah,
can give
so
us the
left main is
size.
So huge.
So
Question is, do we go with the 3.5 or 4.0?
So actually, the start of the pullback, the vessel size is
No, don't not start off the pullback, but just the left main.
okay.
No, but you have to go to the LED also. I would go with the 3.5 so that we can go to the LED too. Remember, it's not only the left main, we have to do the LED too.
Left main is
Left main lesion is
huge.
very
The lumen
short.
is more than 5.
It's not a lot of
But the
calcium
start
there.
of the pullback, the lumen vessel size is like
There's not calcium
3.4.
there.
Yeah, 3.4, that's fine. 3.5. Get ready.
So,
yeah.
Samin, can
The-
Annapurna, that lesion looks more
Yes,
in the
not
left
calcium.
main calcified. The ostrom of the LED looks very little calcium.
Yeah,
Maybe we should
exactly.
use a 4.0 for the left main.
exactly. what I was
See this
telling
now.
Now, for discussion sake,
So
I'm
look at
asking,
this now. I'm going to go fluoro now. Guys, go on fluoro also one side.
What we would have done otherwise?
Yeah.
Do we need
Look here, see this now. Look at the degree of calcium. Tram track of entire LED.
Yeah, sure.
Distal left main, very short, and then entire circumflex. So key is, I think the point is that as Bhupati asked earlier, what I would have done before IVL time, we probably would use a 1.75 or 1.5 and then 2 bar, or 1.75 or 2.15 bar, because that you can go through the 8 French guide. With the IVL, we are saying that try to avoid the step bar, use 1 bar and then use the appropriate size IVL. We know that in this particular case, there is a disparity. Left main is about 5 millimeter and LED is about 3.5 or so, 3.75. So I think compromise having a 3.5 probably reasonable. Because even if you use a 4.0, what is the size of the left main? Left main is at least 5 plus.
Yeah, I believe it's more than 4.5.
Yeah, 5.3.
Now what?
And so. So therefore, that's where it was. So key is that now 2 over, could I use the 2 over? I think 2 over would have been a little more aggressive in this kind, knowing it's a long lesion and very tight lesion, that it's reasonable to use a 1.75 strategy what we had. And that is what we are trying to teach everyone, that use a rotor-tripsy combination and start with the moderate size burr. Don't go to bigger one, because higher the burr, we know that more is the complication. We can remove the rotor wire. You have to remove the rotor wire when you're doing the IVL, although you can leave it, but there's no reason to leave it, because then it will not produce their acoustic shocks. Good.
Good.
Go to 4. Start. Yeah, good. Now guide should be out.
I want to go in, wait.
The 3.5 looks a good choice.
Yeah.
I think for IVL, you don't need to go for the vessel size rather than the contact is the more important thing, because I think a 3.5 will just touch everywhere and that's enough to break
Negative.
the...
Good.
Now, whether it will touch that left main wall, because it looks
No, I
very
think you
open.
just need the contact, the lesion contact. I think the vessel, you don't need to go all the way big.
And see that even with IVL, more blood pressure, decrease in pressure, because it's occluding both circumflex also. So this is always the question comes.
Uh, uh, d- d-
Yeah, the blood pressure is the
I
issue.
mean, to answer Bhupti,
Okay,
in
go,
US,
go.
I think
6.
2.5 is going to go away.
Down.
We'll only have CP. Yeah.
Yeah.
and that I was so
No, we'll stop it.
chunk
Right
of
now.
No, we stop it.
calcified
Release, yeah,
nodule
yeah,
and
yeah.
proximal LAD.
There's
And
no,
if
there's
you
no
see
calcium
the,
in the LAD as such. Go to the proximal LAD.
Yeah,
Back.
here, like I can see the 360 calcium.
Yeah, 360. 360 calcium.
and calcified nodule
But calcium,
actually.
let's say the
It's a
pressure went
nodular
up or no?
calcium.
Pressure is very low right now.
Where?
And if you see that your catheter is adherent to that nodule, maybe in this case tuber may have some role. If you see that proximal if you come, there's
pressure
a
is
big
Go to the
calcium nodule.
Yeah. So we go to the left main once again. Let's do the left main once again quickly.
I
This
think we
is
have done the left
proximal
main.
now
Yeah.
comments
No,
are coming.
no, no.
Okay.
Go back here.
Good.
This is the distal left.
Not going now.
Okay.
There's also
Yes,
360.
Going on.
the double wire.
Nodule is an adverse thing for
No,
IVL.
6. Yeah.
Will it,
Actually, you need to
cause
shave.
the
Yeah.
burst or
Yeah.
rupture
You
of
need
the
to
balloon?
shave that, and IVL will not shave the calcific nodule. So there you need an orbital or rotational atherectomy. We actually just have sent a paper which is accepted in JAC intervention. And do you want to talk about that?
No, it was a
Calcific
case
nodule.
report of a calcific nodule in the left main, essentially showing 2 kinds of cases, which is a better, I mean, we have done many cases, but I think if it was a short series, based on that, we have showed 2 cases. That when you have a calcific nodule, which device probably works better, likely rotational atherectomy rather than shock wave. And of course, we are going back to the same question, when would shock wave? Imaging definitely would help us, because you need more than 3 quadrant of calcium before we think we have to do the shock wave. And
Ruptured.
yeah, okay.
Yeah, even we actually have seen some few
I think that
shock wave balloon
nodule,
rupture.
nodule
Yeah.
is where this rupture has happened.
Yes,
Yeah, good.
that's
But
true.
I hope
Whenever
it has
there's a
done its job.
rupture, there's always a nodule there. Yeah.
So yeah, calcific nodule will not react that much to the shock wave. What you need to shave that nodule by rotational atherectomy or by
I think
orbital. Yes.
tuber will be better in this case.
Can we have an imaging now?
Yeah.
Whether the rupture of the balloon produced, what is the impact of that ruptured balloon
Ready?
on the wall, or sometimes it dissects throughout up to the artem of the left main. Sometimes it may change the whole plan
Again,
of
proper
how
injection.
it should be.
Okay. You want to do imaging again? You throw away this. We may need a new one. Yeah. You want to do quick imaging and dilate with a high pressure balloon, 3.520?
No.
4.
If you are doing circ, we should not dilate the LED now. Just
Okay.
go to the circ.
All
So
right,
we'll do the IVUS again.
Yeah, definitely. This is the yeah.
IVL balloon or non-compatible?
IVL.
IVL balloon.
We are not using any non-IVL balloon yet. Get a filter fine toss
So
ready
that
for
was
the
just
circ.
at 7 atmospheres, is it?
Yeah, 6.
6 atmospheres.
We didn't go to, we wanted to go to a little more later, a particular left main, but didn't get that chance.
Show the IVUS back. Okay, don't.
Dr. Sharma, that OP and super high pressure balloon, is it available now in?
No, it's
No,
not here. No.
No, we don't have that
Just
yet.
keep it
Yeah.
proximal.
FDA
We can do that
approved
part.
from
Yeah, good.
March
Good
2022.
reference. Okay,
Yeah.
I'll start
Talking
to work.
about it, but it's not approved yet.
Not.
Is also 180 calcium. Yeah, come to proximal. Yeah, some like border dissection looks like, yeah, lumen much bigger. Yeah, I see the deep fluctuation.
You see the,
Yeah, much
crack.
bigger lumen. Yeah.
When, go back and
Looks
show
like
it to
not
them.
protruding, just a lot of plaque burden, calcified plaque burden. Yeah, a lot of plaque.
And
Much
cut.
bigger lumen. Now come to the left main.
Good.
Yeah,
Floor.
lumen is much bigger.
Good. Okay. Okay.
Looks like not so
Nothing
much
happened,
protruding calcium.
drastically.
Yeah. But except the lumen got better, we saw few cuts.
Can you go back
Yeah,
and
yeah.
show them where the, you have the shock wave created that cut?
Good.
Yeah,
But
looks
it's
like
both shock wave and the rotor.
Yeah.
Yes.
Yeah, like a lot of
I
plaque.
have
Of
a
course,
question
OCD is
here. Would
better.
a balloon rupture at the low atmosphere would indicate using a higher size burr?
Yeah. So that's, I think the question comes here is that have we created enough crack in the calcium? So in this particular case, more important is what about the circ? We still have to take care of the circ. So that, let's do the circ now. You want to take a picture in this view?
No, I think we are good.
So let's take a picture in this view. RAO. No. We go to that what we have, RAO 22. And then we decide that do we do a circ rota and do we increase the burr size? Because only thing is with the 7 French, we can go to the 2 bar. You want to take a picture now first?
Yeah.
No,
But
no
I think
point.
right now we have-
Yeah. No, no.
Anu, I agree with you. I think.
Yeah,
we
no
both are
point
saying
going
the
with
same
the, yeah, same thing. Exactly, go.
Yeah,
that,
no point
at
going
the-
with the higher burr.
Yeah.
When
In
you
the
got a
circumflex.
good lumen with IVL and the first rotor.
Go.
Yeah.
If you did not get a good lumen size, then we obviously will go with a bigger rotor burr. But when we got a decent size of a minimal lumen area right now, when we crack the calcium and there's enough dissection that we can go ahead and put a stent in, but we have to work on the circumflex. Is that correct, Anu?
Yes.
what you're
Yes,
saying?
yes. That's our plan. Exactly agree. And I think going back to his question, that his question is if there was a rupture, that is it an indication that the lumen is not, we haven't done a good atherectomy or haven't taken care of the calcific plaque. Is that an indication to do rota? I think that's not an indication. It is just telling us that we have done something to that calcific plaque. And by imaging, we saw most often when we see something like that, it is a calcific nodule that causes rupture.
See if there's a
Which is a good sign,
fold
actually.
there. I mean, so Wolverine. So
Any
the
comments
cir-
from the audience, Ronnie?
Yeah.
You want to go to another
caudal?
LAO caudal? Yeah.
Okay. Camera away. So we're going to LA caudal.
The rupture of the IVL balloon is always a feared complication. They said that the modification what they brought in to the IVL balloon, the latest version,
Yeah.
is less
Sometime.
prone for rupture.
Yeah.
But in spite of that, we saw that right now we got that rupture.
Yeah.
Usually, if there is a ledge or it's a protrusion, that
Yes.
always when the IVL burst is released, that causes the rupture.
Let's do a cutting
that
balloon
spark
forum.
just get into the fabric and then it breaks the IVL. And the energy is dispersed onto the wall of the vessel, and that causes extensive dissection. We had such a disaster sometimes. Hope it will not extend into the aortic wall.
Yeah.
So
No, we always are concerned about that any balloon rupture at the level of the ostium.
that's right. But this
Yeah.
is released with a high pressure, and you saw that bust how it delivered the contrast. It may go just like that. Into it.
So now here is the dilemma we have. Yeah, circ is wire is not going because it's still a tight plaque. So I would say that let's do the cutting balloon with a 4O. We have the Wolverine. Let's cut and then we try to wire the circumflex because we still need to take care of that the plaque at that level.
Okay, leave it here, leave it.
Okay, give us. So we have the 4O Wolverine 10 millimeter. Actually, we are doing a trial. It's otherwise not available yet. 3.5 4O. I know other places, even for us, we are doing a trial called rota cut. And goal there is a small rota burr using cutting balloon versus rota plus regular rota means 0.5 burr to artery ratio followed by high pressure and then stent with the imaging endpoint. So this case, so we have our Wolverine of 3.5 and 4.0 available to us. So that's where we are now. We have a 4.0, 10. We are using it now to modify the plaque further so that the wire can go. Maybe we need a little stiffer wire than just the floppy. I think take this one out. Yeah, 1 second. Let me take this
Just
out.
for
Yeah.
discussion,
Yeah.
what the people think about going for a cutting balloon here or a high pressure NC balloon? Because you got some cracks already. Should we go with the...
Go where? LED, left main?
Left main,
Multiple
yeah.
places. You have to just go and put the stand. That's what I feel. It will yield very nicely. They
No,
have
but we are
broken
not
in
there.
several
No,
levels,
yeah,
in
yeah.
several
Yeah, yeah.
Okay,
angles.
good.
No, but remember, we still have to
whether
take care of the
cutting
circ.
balloon or a NC balloon, high pressure
Yeah.
NC.
You can use
to
a
get
NC
more
balloon. NC balloon.
16.
So the
Yeah,
question
good.
is actually, if you had a wire in the circumflex, would it be still going with the NC balloon or cutting balloon or a direct stent? But
I would say
here,
if the wire in the circ, you have done the rotor of the circ, then you probably go with any high pressure balloon will be okay. But I think we are not there yet.
Yeah, we are not there yet.
Yeah.
And Dr. Sharma, I just want to ask you, what about the OM1? There is so much disease
Yeah.
in the circumflex.
Oh.
What is your strategy?
No, our goal was.
Yeah, right now we are not focusing on OM1. That should have mentioned right from the beginning. When you see a
Right.
vessel like this and a lesion, your focus is left main LED proc circ. The rest you want to leave it alone and keep it for the future.
Yeah. And we had to, this patient is coming back anyway before the RCA.
Good.
So in
You want to
few
go
weeks
here
we are
because
going
we
to
are
bring
covering
the
this
patient
area.
back.
Yeah.
So
You'll see that we are still struggling from left main to LED now. We haven't even gone to proc circ area.
Right.
and you may need a Miracle 6 or Gayatri.
Okay, go up here. Miracle.
Miracle
Let's see.
6.
Let's see after this what will happen. Okay.
Good. Yeah, same. Yeah.
Okay.
You know, the question is, Bhupati asked that question about this burr and a step burr. I know some other person, panelist asked that question. And I think that's the issue is, maybe our old technique we would have done in this particular case.
Yeah.
1.75, 2.15 burr. We probably would have been getting ready for the lecture. Okay. So now we rewire.
We don't know what we have created in the circ.
Yeah. No, but we have to put a stent first. I mean, open ostium of the circ if possible.
Go.
Yeah,
Pull
pull back.
back.
Yes. Because otherwise, once you put a stent, now, if there was no disease in the circ distally, there is a very large OM, which is, or medium size OM, which is 95%. So we need to put a stent across and probably open the ostium for the future. So that's the part.
Wait. Don't destroy it. Yeah.
Can we go a little more RIO or something like that? We can see that working area becomes much more clear.
Yeah.
That's better.
That
Circ
becomes
is
a
almost
problem.
up to.
Yeah.
Subtotal,
we are
yeah,
in
from the
trouble.
dissection, probably acute vessel closure.
Or no, this is we did a cutting balloon
Can
there.
you do a cine? Take a
Cine?
cine.
Okay.
So I understand exactly.
Yeah.
Can we go to LAO caudal or something like that to see the...
Can't see it well. We did earlier.
Circ better. Okay.
Oh.
Yep.
Yeah, that's subtotal.
Okay.
Yeah.
Anyway, impala is there, so it should be okay.
Yeah.
One more.
So these are the situations where
Yeah,
I always
now
feel
we
that-
know the importance of impala now.
No, so
Yes.
I think impala is like a seat belt.
Yeah.
Anybody can drive at 70 miles per hour with or without seat belt. You
It's
can
a
decide,
different
right?
guide. Wow.
81-year-old, EDP is high.
Yura.
You want to protect yourself and protect the patient as well. And one more thing for the reason I'm asking about OM1 is because I think youngsters should understand now all of us are pushing for complete revascularization. It doesn't mean all the things have to be done in one sitting.
Yeah.
Make sure that you left main, you get away with left main, which is the most complex in this patient, and OM1 or RCA you can address later on.
But what kind of sheath, this 45 kilos man, what kind of sheath he will take in the groin?
We always use the
That's
long
also
sheath.
Another problem.
Yeah.
Yeah. Right. So I think the question was what large bore access.
Large
Yep.
bore access,
Right.
and also he is a CKD stage
Hello?
3, and there will be a lot of calcium will be there in the groin, and that also makes not only during the procedure, after the procedure you will have the nightmare.
Some die.
That means it will keep the
Go to the-
surgeons awake till the night.
Die.
Ma'am.
So I know where it's going.
Would,
See?
would
Perforation.
the like if we had had the wire in the circumflex even at the beginning of the procedure, would it have?
No, but because rota could not have done the rota, remember? Very
Yeah.
good.
So no, madam's
Sure,
question is
sir.
after the
Die.
procedure before the IVL.
There's some wire perf.
For the IVL.
Can you give die so I see where we are?
Does the wire perf?
Yeah, yeah, there's a wire part. I think right now we should put a
Giving the
stent
dye.
across.
So I see where the circ wire is in the small branch, or am I in the
It's
main
in the small
vessel?
branch.
Okay.
So in this situation, let's put a stent here. 4O. This is it.
I think it's
430.
still okay, right, Anu?
Yeah, I am in the main circ, but this is a miracle 6. It's
438.
not making the next turn there. 4038 Zions you have.
Yeah.
To answer Dr. Jayanti's question, people have used two guides and put a guideliner inside the ostium of the circumflex and ablated the left main LAD through two guides. There are some reports available
It's no good.
at the circumflex system.
Okay, you want to leave it?
Let's put a stent right now, yeah.
The IVL probably altered the
No, actually more,
No.
not after IVL, it more after the cutting balloon. Remember there was still circ was there. After the cutting balloon, now the circumflex flow has decreased. And that's where same strategy changes. In this particular case, it's okay now that we stabilize our left main to LAD first, which is the vital. And then we worry about the circ as a part 2. Good.
I would agree. So, I mean, I think the most important thing is to fix that left main LAD and worry about the circ afterwards.
But the ostium of the circ was looking clean, right? In the
No, it's
very
heavily
Very
diseased.
heavily
Yeah.
diseased with calcium and angulation actually. Good.
Okay, some die. Let's see. You want to go to cranial?
Yeah.
Okay.
Good. You're okay.
Okay, go up. So this is a 4038 Zions.
And we can take a 4.5 high pressure balloon for proximal pot.
Every time we touch the left main to LAD, his pressure drops.
Despite impella.
Yeah.
Now provided this is it's not a CP, it's a 2.5. But that is what we used to use before anyway.
Okay, ready? CP.
Oh, it's
CP.
a CP. Oh,
Yeah.
sorry, it's a CP.
Go.
Okay,
Yeah.
a CP.
Okay, circus, bye-bye.
Yeah. No,
That was
bye-bye right
beautiful,
now,
yeah.
but let's see. The LED is
Okay,
good. Let's go
touch,
to the
don't
caudal
touch
view.
this
huh?
vessel. No, I think don't go post-dilating, nothing. Let's try to get into the circ if we can.
No, but you have to post dilate, then only it will go to the branch. And get a whisper wire. Get a 4.5 balloon. You have to open pot. What do you need now? Just do the pot there and then we put a,
Yeah. I mean, just to make sure that wire doesn't go behind the stent strut.
behind and the
Probably
ostium
not-
opens a
not
little
a bad
bit.
idea.
And then we try to use a, right now blood pressure, everything else is good for him. Show the lead, the 6 lead ECG also. Okay, at least 6 lead, there's no ST elevation. This is 4.5 balloon. And give me the whisper wire. Good.
Not whisper. Only question is, do we go with the
So I also say that knowing that, remember this patient has a little bit of wire perf. We don't go too aggressive for the circ right now. We create a perforation, create more trouble. That's okay. Knowing that hemodynamically good and probably circ also has some collaterals. So the goal will be that we don't go too aggressive. We stop here and try to do it simply. We can go without much hassle.
Go.
Yeah. And if any question, the wire going not where we want, we bring this patient back. And patient is going to come back anyway. Okay.
Yeah, I think that's
16.
a very good strategy. I mean,
But
Yeah, I can see
why the
upper
whole
range
question,
of
will come knowing that done these cases thousands of times with a step bar approach and get perfect results and so could that approach would have been a different outcome like what we get in this patient right now. I mean, it always remains in the hindsight that we want to improve your strategy, and sometimes maybe the new strategy may not be better than the old one.
I completely agree with Samin. I would say that IVL didn't do what we could have got with a stepwise burr.
Right, step bar, yes.
Let's give try fielder again.
No, yeah, fine cross with whisper. Yeah. Good. Pressure is okay. Although a little lower side, usually it's even the guy running high blood pressure. But saturation is good. Good, little less, 92. Gone down. So many of these cases, we rarely leave the impella. We just convert sometime to the balloon pump, if need to be. Even in the Protect 2 trial, I actually have one of the top enrollers. We have few cases left after impella, we got trial, then just replace them with a balloon pump, easier to manage. Although impella can be left also alone. I mean, can be left for, yeah, it will be.
So I think that option we don't have in India.
The miracle.
Everybody fly BP.
Yeah.
You're the miracle, right?
Okay. Yeah. Get a miracle.
I have.
Just.
Do
One
we
more
need a
try
super
with
cross?
this. Huh?
Super cross.
Or other question is use a super cross or over the wire.
I have it.
Huh?
Let me see.
Floro? You want venture?
No, venture is not going to do it.
The other question is use those angulated catheter to make a turn, because now it will be, guide has to come out a little bit.
Yeah, we have got a telecross. That
Yeah.
is a micro catheter which has got an angulation. We have got a 90, 120 degrees.
Yeah,
so
that's the
that
same.
it can be
Yeah, we have the super cross. I'm sure it's the same name, or maybe different company. You ready?
Out.
they always successful. For me, they are not. Maybe I'm not as good, but I always struggle with all this, the twin pass, supercross, venture.
Yeah, it increases the complexity, and then your assessment
Over the
should
wire
be very
venture.
careful actually. For all
Let me
the
see here.
performance.
I need to see exactly where the vessel is.
No, we
What
see the
wire
dye.
you could have
Yeah.
taken, Ramesh, for this access to the circuit? They taken a miracle.
No, that's what we are.
I mean, I
We
think,
had the miracle.
No, they're saying what wires we could have used. So always you try
Yeah.
a polymer jacketed, wires which are either fielder, whisper. We tried that first, did not. Then you think it is behaving like a calcific subtotal vessel, which means you need your specialty wires, stiffer wires. Then you started using your CTO wires. So we started with a miracle.
Right approach.
Yeah.
Anu, only one thing I was going to ask you. You almost had it in the proximal circumflex, and you had
Yes,
a
yes, you would have.
microcatheter.
Yeah.
I advanced the
that point,
microcatheter
could we-
also, yeah.
Right,
Okay,
could
now
we not
here,
exchange that wire to a softer wire?
No,
or
but
even
didn't
a
give
polymer
enough room.
jacketed?
it did not give enough room for us to now here.
Okay.
See here, it is.
Right now, see, that's where you are.
Now this one we are going, sir.
Get angulated catheter here.
That's a
120.
venture, you're saying?
No, right now we have both super cross and or or venture ready, so whichever way we want, we definitely will need one extra. Yeah. And flow started coming, many times just with the wire, you start getting a flow. TIMI 0 becomes 1, 1.5, that's okay. But here right now we are just TIMI 0.01.
So, I mean, retrospectively, seeing what happened, I was just thinking that after the road ablation of the LAD,
Yes.
if we had simply road ablated the circ and then done what we did, would that have been a better idea?
Oh, you mean before the IVL?
Yeah, rather than using.
Yes. Do the road
So
ablate
I mean,
LAD,
no,
because
but
otherwise we would
question,
not have
remember
got-
the whole question there was, now we have to take the wire out from the LED left main, and we are not prepared that vascular bed, and then we'll be doing the, I say what I would have done otherwise without IVL. Let's say use one bar approach, then I definitely would have used bar
Supercross.
followed by the balloon, and then
120
put
or
a wire
90?
into the side branch. So key is that rota alone will
Okay.
give you very small lumen and may still be a trouble, and that's why a lot of people talk about putting a two guide and put the guide liner on the side, and then you still do a rota, leave the wire, and so
You
forth.
have the fighter wire?
Yeah.
Fighter?
Yes.
Fighter.
So because of that, yes. So key is, goal always was, but not with the, too complex situation, but we wanted to do the wire. So question is wire only after the rota, or you do wire after have done some, the additional adjunct after the rota, knowing that it was a moderate debulking of 1.75 in a 4 millimeter vessel, 4.5, which is like barely 0.3 bird to artery ratio. So that's where we are. Yeah. Okay. So now which wire you are using now?
I'm with a fighter.
There's another wire. We actually, Anu has made a very nice guide wire app, and these are all the properties of all the wire, which is very little teaching happens. Everything is in all those, about those wires are written, created with the case library, and so. I think this case you need to go with the Supercross or
Okay.
so. The limited time, yeah.
Open the Supercross 120 then.
Supercross 120 and exchange length fielder. Yeah, this wire is not helping you. You just need to open one cell and a little bit of 3 RBCs to go down. And that will make things better. See?
Agreed.
Yeah.
Agreed.
I think the flow
I
is
think-
seen.
Yeah,
Little
Anu
bit.
is right there actually. Yeah.
Yeah.
And Dr. Sharma, we'll
Yeah,
skip
good.
your lecture for and we'll just watch it for the next 15 minutes.
Yes.
We have time until 9:30.
Okay.
Is that okay?
Yeah, that's perfectly fine. So I'm sure people want to see this more than any lectures or so. Whole purpose is seeing the live cases.
Yeah.
Ah.
A real life situation.
And this was the real complex. A lot of people will not do this kind of case, but our goal is go through the struggle, sweat, and that struggle is the what people want to take back in their practice. That when they encounter those trouble, what are you going to do? Okay. So now we are ready with the fielder, and we need to make a curve and 120. Yeah.
Yeah.
With a Supercross 120.
Yeah. Fielder will go. That's what our field. I would
Okay.
have taken first, before Miracle, I would have taken fielder.
No, we tried fielder.
First,
That was
remember,
the first
wire was
fielder.
the fielder.
Yeah, we said that the first always try fielder or whisper, whichever your choice is.
Right.
Yep.
Yeah.
Yeah. No, our first wire
What
was.
is fighter wire?
So fighter wire is made by Boston Scientific. It is hydrophilic coated, but more important is the tip is tapered. Tapered tip goes up to 0.009. So what happens is when you see that it's just one barely half an RBC is going through that area, then these wires are good to go into the side branches. So which are the wires are very good for the side branches? Always try fielder whisper first. They don't go, then you start using this wire, but has to be very cautious, like we said, like we saw here, some wire perf and all this can happen. So this is a fielder. Again, it makes a turn, then does not.
No, but go inside with that now. You have your device.
There must be a spark that is obstructing your further progress. Yeah.
Good.
So there's a huge chunk of calcium there.
Yeah. Yeah, here question is, do you want to now use your
Now get a Gaia.
Gaia 2? Gaia 3?
Yeah.
Okay, let's get a Gaia 3. Where we open that strut a little bit, and this is now we have 120 super cross.
Some die there.
No, you're exactly there.
I don't know. See there? Thing is 120, maybe curving too much. Maybe we need 190.
But the tip is very soft. Actually, when the wire goes, sometimes the curve.
Yeah, that was the reason we were thinking, do we go
becomes a
venture
straight
versus
and then
supercross?
it doesn't do the purpose, actually. It does
That
not
is
stay
true.
120.
Yeah, no, always. That's always the trouble.
Means then do we go with the venture? Venture actually is
Go to
a
our venture.
little stiffer.
Yeah. And the advantage of the venture is that you can keep it changing the angle, because 120 or 90, they remains the same, and it just becomes the trouble. So right now we are using
Need a little curve.
no,
It's
because
not
angle
going
it,
good.
yeah,
It's very hard to advance here.
it goes through the.
Morning, sir. So, the role of a repeat part at this moment with the larger size balloon, because we are seeing some ostium of L6 flowing. And
No, we
used
did.
some 3-4 wires.
We already did a pot. No, there's no indication for repeat pot now. No.
No, but pot means we have done the pot with a
Yes.
4.5.
No, he's saying we went with wires, but we are in the lumen. We have not gone outside the stent.
Yeah. Get it.
The problem is the calcium beyond the ostium.
Yeah.
That's what not allowing the wire to progress.
No, are you saying repeat pot because it is establishing some flow? Okay. Yes. So, Anu, it's not because we went with the wires. His question is...
In mode.
Yeah,
Wire
you
mode.
got it.
Yeah.
So
No.
his question was that actually because of the increased flow, whether we can expand the cell with doing another bigger pot.
No, here is the issue also, your risk in terms of the wire. Yeah, good. Better flow.
Yeah, good.
Yeah. You got it.
We got more than 3 RBCs. So, which is
Yeah,
very
yeah,
good.
right.
Now
Excellent.
it doesn't gone.
Excellent, excellent.
Okay. You want to see where we are? In the lumen or outside? We saw that once.
Yeah, it looks like it was in the lumen, but yeah.
Yeah.
No.
This is Gaia 3, right?
Yeah, Gayatri. Yeah.
But we saw good flow, right?
Yeah, we saw
Initially,
that,
for a minute we were there and then we lost it again. Okay, give me the venture quickly. I'll try with the venture.
Which wire you put in the venture?
And all your patients like such, Dr. Sharma, are you moving towards MAC or general for these type of long cases? Or,
Yeah, some of the cases actually, it's probably better off. Put any fielder, any.
Yeah, okay.
Yeah.
I mean,
That's it. So-
especially CTO cases I'm asking
yeah.
about. Yeah.
So I know a lot of people do. I mean, we are not gone that
we
much.
don't yet.
Yeah.
Yeah, you don't do it yet. Yeah, good.
I know maybe once you coordinate with anesthesia, maybe it's a better approach, some of these patients. Good.
What is
Question
other?
will be which other wire we need. Go. Earlier at one point, it looked much, there was some blood flow nicely. Anyway.
Yes. There was almost like Timmy 2 flow one time.
Yeah, good. Okay. Rotate the whole thing and down.
Where is the wire?
No, wire has to be, once you point down, then only we bring the wire.
Always ahead.
Yeah. We did already. Just 1 second. Pull back a little more. No? Good. But it's just some channel we have created, which may not be the
Okay.
right channel.
Okay, wait. Let me do it. This is, okay.
Undo. So key is with a venture. Anytime you made a curve, you have to undo it, then advance. Good.
Yeah.
Destroyed now.
I mean, so far we have seen a very complex patient in terms of age, frailty, comorbidities, and including
Can
low
you give
body
some dye?
weight, and having a successful PCI of left main to LAD. And obviously, we have to bring up flow back into Circumflex and RCA PCI, which could be done at a different time period as well. You know, will definitely work. I'm sure Dr. Sharma and Dr. Kinney are going to work as best as they can. And even if in 8 minutes we'll go offline, but they definitely will do their best to get that vessel back. If not, I think there's nothing wrong
Let me guide
as long as the patient is not having chest pain, hemodynamically stable, to bring the patient later on, you know.
All the other downside is the dye. The more you inject with the creatinine too,
Yeah.
I think we may risk this contrast-induced issues.
Absolutely. That's a very big factor for these patients. And hopefully there are some data with the Impala that may prevent CIN and these kind of cases. But I don't know whether unless you have a good full revascularization, that will be the full correct statement. But that definitely is one of the point. But saturation good, little bit of ST depression, blood pressure is all right.
Can you give me pilot 200?
Dr. Shamin Sharma,
Yeah.
you are going to keep the impella for a little longer time now?
Well, that's a very good point.
Or
That's
change
what we are
to
thinking.
balloon pump, likely.
Yeah. So again, the more you do this 14 French sheath, that definitely cause more trouble, ischemic in these calcific patients,
give some
calcific
dye, so I
vessels.
know?
And so my goal will be that we'll do a 12 lead ECG unless there is ST elevation or massive ST depression, and just change that to a balloon pump, which is 7.5 French. And we'll close the Impala side left. We have the 7 French sheath on the right, and that's where we will change it to the balloon pump.
Thank you.
Yes. Okay. Yeah. You want this wire? Okay. Now, which using a pilot 200.
Yeah.
We have got 6 more minutes,
Yes.
Dr. Sharma.
Understood. Yes. Absolutely. So
No
only
pressure,
question.
no pressure.
So we'll skip. Yeah. More important, the lecture. Maybe we'll have some time in the future. But here is this that can we salvage it in a timely fashion? We probably will work after going offline, maybe another one, whatever require half an hour, as long as we don't give much dye and there's no wire issues, that we will just continue, try to use some other techniques. Question is, what else would we use? We already have used both of them, maybe just a different wire, micro wires and so. So right now we're going with the pilot. Yes, Ramesh?
Yeah, Dr. Sharma, I want to ask you, this is nothing to do with, obviously, this particular patient. It's
Yeah.
12 o'clock midnight over there.
Yeah.
And I know you and Anu are kind of workaholics. But nowadays in the US, we are now talking a lot about work-life balance. Could you comment on that if you don't mind? And
No.
Anu, you also please chime in.
Yeah, so welcome. The work balance is simple, that you take some time off. Don't make 12 midnight every night. So I'm actually 12 midnight, usually Tuesdays and Fridays. So then other days somebody else does it. So that way. So yes, clearly all these things are very important for a long-term efficiency of the healthcare workers, which are exposed to the various health hazards. And goal there is that you have a combination of work at the same time. So that's why we, just be open on Sunday. So Sunday we actually have 18 elective patients right now. Any inpatient, whatever 5, 6 will be. So we usually do Sunday about 25 patients. So that's part of the same. It's a little easy. Sunday there is less pressure. Everybody try to keep a simple cases from 8 to 4 and
Can you
so.
give some So we see, otherwise I
So
think I
this
want to
is,
change
yeah.
the,
Yeah. So good.
so,
It came back again a little bit. And tell this
Yeah,
is the
little
pilot.
better flow. Yeah.
You
No,
see.
no perfect, but there's better flow in the wire is probably going and then.
So right now we actually, our venture is in the circ. Whether it's a true lumen or not, we don't know. But
But
it
the fact
definitely
that
is in
we
the
saw a
circ.
little bit better flow,
Yeah.
compared to zero flow is a good sign.
Yes.
Okay, take. Okay.
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 Now, do we want to change to some other wire now?
Which wire you want now? Tell.
Maybe a run through.
Before you progress,
yeah.
should we do a
Some-
one more
some di-
imaging so that we will be able to be in a better position to have a look at that, where exactly we have to enter, which is, or we are seeing some.
I think that your venture is definitely in the main lumen because your wire is going to two different branches.
Branches.
I think keep the venture there and change the wire. That's it.
No, if they are in the venture, is definitely in the circ. Workhorse wire may be a better
Right.
Yeah.
stuff
See this now?
rather than a,
Now we do a run through. Yeah, get a run through now. Look
I
at
don't
this.
think we are in the lumen.
So it started getting better. Little STs are little better. Good. We change to the run through wire now.
Yeah.
Okay.
It's not-
So I know that timing, we are just getting to it. And it, of course, it's not 2-minute procedure now. It's going to take a little longer, but I just want to stop here and that we will continue our part. Yes, I hope some of the important points we demonstrated, but at the same time, probably learning that in a heavily calcific lesion, maybe just a rota and IVL may not be the right approach. Maybe just you do your sequential debulking or plaque modification, actually with the stage step bar, and then decide whether you use IVL or so. Knowing somebody which is such a bad calcium, it's not even a severe, I'll call it a massive calcium. And with that note, I really thank all our TIC committee to giving us this opportunity and all excellent points by all the panelists and moderators. And we just want to say it's a 12 midnight and your time being 9:30 a.m. that we wish you for excellent 2 days. One already started last night. Another 2.5 days of the massive and very educational this meeting.
Thank you, Samin, and thank you, Anu, for an excellent demonstration. I'd like to thank all Cath Lab staff of Mount Sinai for staying with us till 12 midnight. From
Thank you.
behalf of TIC, thank you so much.
Thank you. Thank you very much.